This is GIT 5. Small intestine. If we have dilated small bowel loops with no fold thickening, just dilatation, could be obstruction, could be scleroderma, could be sprue. So dilated small bowel with no fold thickening, this is most important, no fold thickening. That means the mucosa are normal. Mucosa are normal in obstruction, sprue, and scleroderma. And this is the appearance of dilated loops without abnormal mucosa. Dilated loops without abnormal mucosa, with no fold thickening. What causes multiple small bowel masses? Could be polyps, could be lymphoma, could be metastasis, and the most important is lymphoma. Mind you that lymphoma are elevation of the mucosa due to lymphoid tissue hyperplasia or abnormal growth. Metastases are usually subserosal. Polyposis are usually from mucosa. So we have mucosa, submucosa, and serosa. Polyps, lymphoma, and metastasis. So multiple small bowel masses are either due to polyps from the mucosal outline, lymphoma in the submucosa, Peyer's patches, and metastasis usually subserosal. These are three sites: luminal, intramural, and subserosal. And these are the nodules caused by mucosa, by submucosal infiltrates in lymphoma. Nodules of lymphoma. Now, when to get separation of small bowel loops? We have an idea about dilatation of small bowel loops, and we said the 3S, the sprue, the small bowel obstruction, and the scleroderma, and the three should have normal mucosa. Now, when we have separation of the normal loops with separation of the small bowel loops without dilatation, this is dilated small bowel loops, scleroderma, sprue, and small bowel obstruction. And this is the multiple small bowel masses, which, as we said, from the mucosa, from the mural part, submucosal, or from subserosa as metastasis. And now we have the separation of small bowel loops, and this is due to either thickening of the wall, not too much separation, but if there is peritoneal metastasis, if there are peritoneal metastasis or retractile mesenteritis or in ascites, the separation will be more apparent. Here there is separation due to multiple lymph nodes within the peritoneum. Here we have a sarcoma. Sarcoma means piece of meat. Sarcoma, which is partly from the wall of the stomach and partly exophytic. And this word exophytic is in contradistinction to the word endophytic. So endo, inside the lumen, exo, outside the lumen. The most characteristic point of GIST or gastrointestinal stromal tumors are that most of the tumor is outside the lumen, and the most common is lymphosarcoma. But here we have leiomyosarcoma. It is we cannot differentiate. We have a tumor that invades the wall, bulging into the lumen, and is seen mostly outside the lumen, this is GIST. So what characterized stromal tumors is the presence of a large exophytic component outside, and the infiltration inside is less compared to that one. Like here, this one, small part and large part outside. This is gastrointestinal. But the most common of gastrointestinal stromal tumor is the lymphosarcoma. Now here we get this we have here some tortuous indentations, parallel lines, tortuous indentations are seen here and there, and this is characterized as fundal varices. Fundal varices are usually appearing as well smooth outlined filling defects of tortuous appearance, like this, like that, here and there, and it may extend into the esophagus, but originally it is esophageal, but could be esophagogastric or gastric, and these are the sites of portosystemic collaterals. Now here we have some changes of the small intestine according to operative interference. The afferent loop obstruction, what is called afferent loop obstruction, is usually occurring after gastrojejunal anastomosis. We have an afferent loop and efferent loop, and this afferent could be obstructed at the stoma, afferent loop obstruction. Here we get fleck of barium, dense fleck of barium at the anastomotic site. This is the jejunum, and this is the stomach, and we have here the anastomosis, and this is the ulcer, and this is called stomal ulcer. Here there is appearance of this. If you cut it transversely in CT, it will appear as two dilated loops like that, but it is one loop exactly like that one. Now, duodenal carcinoma. In duodenal carcinoma, you will find the apple core due to annular carcinoma, or you can get the ironing, the irregularity of the mucosa due to carcinoma in this area. So cancer, duodenal cancer can be either an irregular outline of the mucosa or an apple core appearance like that one. Now Meckel's diverticulum. At the site of the Meckel diverticulum, it is the site of the junctional area between the mid and hind gut. You can find a fibrous tract like that, with a diverticulum or without a diverticulum, or you can get complete continuation to the umbilicus, in which we can get the what we call omphalomesentrie duct. Omphalomesentrie duct, and this is the appearance of the blind loop of Meckel diverticulum. In Crohn disease, the main point in Crohn disease is the asymmetry of involvement of the loops and the asymmetry of involvement of the loop itself. Asymmetry of involvement of the loops, that means that part is not involved and part is involved, not involved, and this one is involved, That one is not yet involved completely, but this one is markedly involved, and so there is asymmetry in involvement, which is called skip lesions. Skip lesions. And at the same time, you can have the involvement is more on one side. This one, for example, you have here some irregularity and it's extending, but here the irregularity is less. So that one is asymmetry of the involvement of the single loop. And in Crohn's, we will get the lymph nodes also appearing and displacing, or we can get cancer, as in this area. So here we have involvement of this loop, and there is a large filling defect within the loop, and there is space occupying lesion in this area, which are the lymph nodes. So lymph nodes, loop involvement with secondary mucosa, and polypoid appearance constitutes sequelae of Crohn's. Many causes can cause, many diseases can cause thickening of the mucosal folds. The pseudowebs seen in long use of non-steroidal anti-inflammatory drugs, and the thickened mucosa in submucosal infiltrations of Whipple, causing thickening of the mucosa, and in lymphangiectasia, like this area, like that area. So we have many reasons to increase the thickness of the mucosa, and thickness of the mucosa is usually due to, as we said, edema, cells, or invasion. So inflammatory edema or cells, infiltration by cells, or invasion by metastasis or malignancy. Now this is the tumor carcinoid, which appear as cartwheel with this appearance. This is a classic appearance, but it can appear in others as thickening of the wall or thickening of the mucosa, as it is here. There are thickening of the mucosa. It's not only, this is not the only presentation. Now going to this one. This is the what we call small bowel intussusception within a large bowel. This is a large bowel, and these are small multiple loops inside the large bowel. So this is the ileocolic intussusception. Ileocolic intussusception. This one is the example of the intussusception as target sign. This one the same. Look for the markedly thickened outline here, and this is another intussusception. So intussusception can be seen as sausage shape within one, another one, or you can see the concertina pattern or the target sign of intussusception. Adenocarcinoma or malignancy can occur anywhere. So the jejunum can be also involved in adenocarcinoma, and would appear as the apple core petal due to annular adenocarcinoma. Now here lymphoma. What characterizes lymphoma? First, we have two types of lymphoma intermingled with each other, either primary intestinal or lymphoma with secondary GIT involvement. Primary intestinal lymphoma can occur in the starting from the ileum down to the colon, and of course it is associated with a lymph node enlargement that spaced the intestinal loops, causing spacing of the intestinal loops. How lymphoma will appear? Lymphoma starts in the small lymphoid tissues in the submucosa and start as small nodules. These small nodules will coalesce together, forming larger nodules or polypoid lesions, which coalesce more to form masses and thus obstruction, and subsequently aneurysmal dilatation or dilatation proximal to them. So we expect dilatation, we expect nodulations, and we expect irregularity of the outline due to larger masses, and we expect lymph node enlargement. These are the components of lymphoma. Lymphoma can obstruct by producing such large soft tissue tumefaction encroaching on the lumen, and thus result in aneurysmal dilatation of the lumen in some parts. And here the principle of being extraluminal, as in any stromal tumor, is present. Most of the tumor is outside the lumen and causing aneurysmal dilatation because of the stricture at this area. So stricture, aneurysmal dilatation, and marked thickening of the outline. Leiomyosarcoma is not only in the stomach, but it can occur anywhere. This is a guest tumor, gastrointestinal stromal tumor. You can say lymphosarcoma, you can say leiomyosarcoma, you can say that it's a non-specific sarcoma. It's a malignant process. Sarcoma means large piece of meat, mainly outside, and the lumen is encroached upon, so it is mainly exophytic and not endophytic. The same behavior as in the stomach, the same behavior of lymphosarcoma in the stomach and small intestine. Here we can get this marked indentation with the lumen compressed and attenuated, but the mucosa is still there. So this is subserosal metastasis. Here another example of subserosal metastasis, and here the serosa is involved, resulting in spaced mucosal pattern and non-filling in some parts, or attenuated lumen in some parts. These are examples of multiple serosal deposits. What is enteroclysis? Enteroclysis is visualization of the small intestinal mucosa done by giving something to cause hypotonia, and to insert along nasointestinal catheter into the region of the first part of the duodenum and then inject dilute contrast. If you inject dilute contrast in the first part of the duodenum or second part of the duodenum, you will be able to distend the small intestinal loops, provided that you give hypotonic, and you will find such an appearance. It is visualization of the small intestine by dilute contrast while it is distensible, starting using a catheter and injection of any drug causing hypotonia of the small intestine, and thus dilatation, and you will get such an appearance, enteroclysis. What is this? We have here multiple diverticuli along the jejunal, which is present in the upper quadrant of the abdomen, but here it is due to involvement, it is elongated, and most are seen as protrusions of barium. What is this? This is the tube which we did the visualization of the small intestine while somewhat hypotonic. That's why the jejunum expands and involve a lot of the abdomen. Enteroclysis with jejunal diverticulosis. Viral infection of the small intestine. Viral infection of the small intestine can cause this generalized narrowing of the lumen. In bone marrow transplantation, such an appearance sometimes are seen. And of course, we know that if there are lymph nodes, it will give such an appearance. So, post-transplant, post-viral infection, and in Crohn's disease, we have this appearance in post-transplant and post-viral infection and in Crohn's disease. Post-transplant, post-viral infection, and in Crohn's disease. You can get generalized narrowing of the small intestinal loops. Small bowel obstruction could be extrinsic due to adhesions, this is the most common, or hernia, or volvulus, or masses and bands like superior mesenteric artery syndrome. So these are extrinsic lesions from outside. The most important is the adhesions and hernias and volvulus. Could be luminal, and the most important is the bezoar, and then intussusception. Lastly, tumors. And the third is the causes of the wall. Thickening of the wall is due to strictures, as in post-operative, post-transplant, as we said, post-viral, Crohn's, lymphoma, vascular, as in hemorrhage or hematoma, and congenital, as in hypertrophic bariatric stenosis, or narrowing at the region between the mid and hind gut. To repeat again the cause of the intestinal obstruction, we have extrinsic causes due to adhesions, hernias, volvulus, and we add here the bands like superior mesenteric artery occlusion syndrome. The second is luminal occlusion, as in bezoar, intussusception, and lastly tumors. And the third is the stricture, general intrinsic bowel wall lesion due to the stricture, as in post transplant, post viral. But first we should put the Crohn's and lymphoma, vascular as hematoma, and congenital as in change of caliber at the region of the junction of the mid and hind guts. Here we have an incision, and we get the following signs. First, that the loops are adherent to the anterior abdominal wall. Some loops are adherent to the anterior abdominal wall. Second is there is a scar. Third, there is dilatation. So, and fourthly, of course, there is a patient complaining. So this is an incisional hernia with superior of the small intestine, small bowel obstruction. Now, strangulated obstruction, we can get additional signs, not only dilatation, we can get this whirl appearance or whirl signs or twisting of the vessels. This is not intussusception, it's not target, it is a twist. It is something twisting, and the vessel inside. So this is twisting of vessels occurring in strangulated small bowel obstruction. We'll get mesenteric edema, we'll get sometimes ascites, pneumatosis, or vascular congestion. So these are signs of strangulated small bowel. Here we have the dilatation, and here we have the congested vessels. These are the congested vessels, perivascular congestion, because we said here there is vascular congestion, mesenteric edema, ascites, pneumatosis, whirl sign. So here in this group we have the dilatation, and we have the perivascular edema and the vascular congestion. If we conclude, we will get that most pathology occurring within in the wall of the small intestine will appear as wall thickening, and most pathology fall in two main groups: Crohn's and inflammatory processes, and lymphoma and malignant processes. So most pathology presents as bowel wall thickening. If diffuse and involving more than one loop like that, this means it is an inflammatory process like Crohn's or similar conditions of those causing strictured lumen. And if irregular with large exophytic components like this is usually due to lymphoma. These are the two main causes of bowel wall thickening. But lymphoma means and other malignancies. Crohn's means and other inflammatory conditions and allied conditions. Here we have again, this is a case of lymphoma, and here we have a case of carcinoma involving the rectum. So, as we said, irregular thickening is malignancy. Irregular thickening with exophytic component is malignancy, usually lymphoma, and the diffuse thickening, like here, is due to Crohn's and other inflammatory lesions causing stricture. Thank you.